To acquaint you with the recent updates in the surgical management of heart diseases. Let me start by inviting my honorable experts, Worthy Brigadier Nasir Ali, Head of Department, Consultant Cardiac Surgeon, AFIC, Brigadier Amir Khan, Brigadier Imran Askar, Colonel Mudassir Noor, Consultant Cardiac Surgeons, AFIC. Let's go to our first talk of the session. I request Colonel Daud Kamal, Consultant Pediatric Surgery, AFIC, to kindly come and deliver us his experience of AFIC for management of adult Epstein anomaly. Thank you, sir.
आगे पीछे कैसे ये नहीं काम आगे पीछे yes बिस्मिल्लाहिर्रहमानिर्रहीम I think यहाँ पे जितनी community मौजूद है we all know each other कि मैं कौन हूँ I don't need to introduce myself so I'm going to talk about the adult Epstein experience I mean specifically focusing on the cone repair. So what's on the menu? So we have these 4 things that I'm going to present to you during my talk in next 7 to 10 minutes. We will be talking about the anatomy of Epstein anomaly. I'm going to share the cone experience, the literature search, and the take-home lessons. So just a brief description of the pathology. I will just go quickly through it. This was a person, he was an anatomist, a physician, Wilhelm Epstein, who was a German. And he published this paper, sounds like personal to me, but it meant like something like on a very rare case of insufficiency of the tricuspid valve. So he described this in 1866, but the word Epstein was used in 1927. So the incidence of congenital heart disease, of this pathology among the congenital heart diseases is 0.3 to 0.8. So it's a rare anomaly. We don't see it that frequently. Sorry. Yeah. So it's a rare anomaly and with equal incidence in both men and women. यार 2-3 चीजें कैसे लेके फिरूं? Okay, sorry. Okay, so anatomy. So Professor Robert Anderson of UK, he is very famous for his experience with the anatomy of congenital heart diseases. He described it, just going quickly through it. The main pathology is actually the displacement of the commissure between posterior and septal leaflet. So that is the main pathology. The second thing which happens is that the tricuspid annulus, it rotates apically anteriorly. It goes towards the apex of the right ventricle. Fourth, there is a failure of delamination. The extent of this failure can be from incomplete to a complete failure, like you can see in severe cases in this part E. And last but not the least, the anterior leaflet is sail-like. So it's actually compensating for whatever the competence tricuspid valve is providing. The other associated pathologies are ASD, VSD, PFO. So we have other things, but main things which we encounter are these 4 pathologies. Presentation and diagnosis, I will skip the neonatal infancy part. I will focus on the adult part. So the commonest symptoms are low cardiac output. Because of low cardiac output, there is fatigue, dyspnea, cyanosis if there is right to left shunt, and palpitation, which is because of dysrhythmias. The diagnosis is usually established on 2D echo, cardiac MR, and Holter and EP studies. So all the patient go for EP studies and Holter monitoring because they usually have an accessory pathways. The commonest is WPW syndrome. Surgical management, these are historical repairs. I would not go into the detail of it. Danielson, Diarani, then the Carpentier repair, but the latest and the commonest is now being done is the cone repair, which was first introduced by Pedro de Silva. He was a Brazilian surgeon, and he first presented his paper in 2004 and presented 21 patients with a mean age of 23 years. So the common steps in the procedure is that you delaminate all of the tricuspid valve, you do annuloplasty of the tricuspid annulus to reduce it to the size of the whatever valve tissue you have. You create a cone of the tricuspid valve, and then you actually hitch it onto the new tricuspid annulus. And this is what it looks like. So that's why it's called a cone repair, that you construct a cone from the patient's own native tissue. So the A5C experience. So I'm going to talk about the surgical technique that we employ, and I'm going to talk about the 10 cases that we have done so far. So preoperatively, we counsel the patients about if we need to replace the valve. Per-op TOE is very important for the adult patient. Now we are employing it for the pediatric patient as well, because we have a smaller probe. We do a high SVC cannulation, that if you need to add a Glenn, so that we can do that. There's aortic and bicaval cannulation, and we draw the temperature 28 degrees. So we start with dividing, we mobilize this anterior and posterior leaflet, and we divide all the adhesions between the free RV wall and the tricuspid annulus. And once we have done that, then we create a cone from the patient's native tissue. So in extreme kind of situation where you have a deficient tissue, we at times use autologous pericardium as well to fill the gap, to give some volume to the tricuspid valve. The next thing we do is that we plicate the atrialized RV portion, and then we do an annuloplasty. We reduce the size of the annulus, which should match the annulus, the size of the new valve that we have created. And in the end, we put a tricuspid annuloplasty ring. Like we all know that we don't have the tricuspid annuloplasty rings. We use the PTFE strips for that purpose to stabilize the repair. So in the end, this is how it looks like. So if, when do we go for a valve replacement? If the regurg is moderate or more than that, we try to maintain an INR of 3 to 4 if we do a mechanical valve replacement. And we add a Glenn if the RV is very thin-walled, if the RV billows when we come off the bypass, and if the patient has very high inotropic support with the right to left shunt, then we always add a Glenn to the surgery. So this is one of our cone repair. This is the pre-op images. So on the left, you can see there's a free TR. And on the right, you can see this is the septal, apical displacement of the septal leaflet, which is almost 66 centimeters. This is a severe form of abstain that we usually would encounter. So this is the picture of the cone. Now this was the patient in which we had deficient septal leaflet, so we had to construct the cone with the patient's own autologous pericardium after treating with alcohol. And this is the water test peroperatively. So this is a competent valve. And this is the post-operative echo. So this is the new leaflet that we have created with the autologous pericardium. Initially, the detachment was almost till this point. So we have created this whole leaflet. We brought up the whole annulus, whole of the valve up to its native annulus, and there is no regurg. So this is a busy slide. This is our experience about the 10 patients that we have done. We started doing it in 2020, and the last case we did a couple of days ago. With the mean age is 26.6, and the oldest patient we have done is a 50-year-old lady. The mean body surface area is 1.64. The commonest symptoms are, as I have mentioned, that the patient has shortness of breath with palpitations. This is in pink, I'm mentioning the displacement of the septal leaflet, which is actually the amount of distance the septal leaflet would travel towards the apex from its native annulus. So the greater the displacement, the more likely the chances that you will have to replace the valve. In the beginning, our experience was that anything more than 40, we would actually end up into doing a tricuspid valve replacement. But with the passage of time now, we have the last one we have done was a very severe form with a 66 millimeter displacement, and we were able to do the modified cone repair where we had to construct the native valve with autologous tissue. So out of 10 patients that we have done, in 9 patients we had the cone repair with 90% success rate, and 1 patient ended up into a mechanical valve. So the rest are the operative details. Usually the ICU stay is around 2 days, and the hospital stay is around 7 to 8 days. The only one patient had the longest stay of 34 days was this 50 years old lady, which we discharged on Friday. She had persistent effusion from the right chest. So that was the reason for her staying inside the hospital. So during this 10 patient, the operator mortality was 0, and congenital heart block, the complete heart block was 0. On the follow-up of 12.5 months, all patients are alive. 8 patients have mild TR and 1 patient has moderate TR. So I will just go quickly through the discussion part. So this is the paper which was presented by Dr. Joseph D. Arani of Mayo Clinic, who has the longest experience with cone repairs, with 235 cones. So I will just focus on the adult parts. So I think he's done 201 adult parts. So the survival is quite good at 20 years, and the freedom from survival, freedom from reoperation at 80 years in adult population is almost nil. This is the experience with the mechanical valve. I will just go into the take-home lessons that you actually would only replace the valve with a mechanical valve if the RV function is good. If the RV function is moderate or poor, you should not put a mechanical valve, because these patients would actually present with stuck valves despite good anticoagulation. So this is the EP part. Usually these patients have accessory pathways. So we always include the EP study before surgery. So two of our patients had ablation before the surgery. So the take-home lessons. So the degree of septal leaflet displacement, our initial experience was that anything more than 40, we would end up into a tricuspid valve replacement. But now with modified cone repair, in which we have to construct the valve with patient's own native tissue, I believe that we can repair any abstain with cone repair. Bidirectional again, we would add, if preoperatively I can see that the LV is quite squashed by the dilated RV. If on the CMR the RV mass is poor, if there is billowing of RV when you come off bypass, and there is high inotropic requirement, and there is a right to left shunt on PFO. Rhythm and rate and rhythm, usually the vein of D is a point which is the AV node, so you have to identify it and stay away from it during your suturing. And accessory pathways would need ablation. And last, that mechanical TVR you would only do if the patient RV function is good. If it's moderate RV function, one should go for tissue valve. Thank you.
Any question and answer?
Excellent presentation, Daud. Just wanted to ask whether do you do cardiac MRI in all patients in all of these patients?
Not all of them, sir. Usually, if on the echo I see that the RV is quite thin-walled and the mass is very poor, so I would go for that, and that will give me actually 2 things. I have done MRI on 2 patients, and that will give me 2 things. Number one, the LV ejection fraction, whether the LV is good enough or not. I missed that part, and that LV, you need to have a good LV to have a good cone repair. So that will tell me about how good the LV is, and it will also tell me about the RV mass as well. So far, the patients that I have encountered, I mean, the RV mass, despite on the echo, I could see that the RV mass was very poor, but on the MRI, we were happy with that. We shared those images with the Mayo Clinic. We have the cardiologist, Pakistani cardiologist, Dr. Qureshi, Yasser Qureshi. So they usually say that this is an adequate mass, so you could go for a cone repair. But we don't do as a routine. So I would only do it if I can see on the echo the RV mass is very poor.
And you are using PTFE?
PTFE, yes. PTFE. We have the PTFE shunt tubes, so I actually split it, take a strip out of it, and use that strip to actually do an annuloplasty.
Do we have any other studies with that
No,
using
for that you need
so
to
because
have a
and
proper
proper
tricuspid. You need
tricuspid
to have a
and plus
tricuspid.
because
Yeah, you need to have proper tricuspid.
because for that we need to do a long-term study on
Yeah.
these, whether they do provide long-term.
Yeah, I personally believe that the aim of these rings is to stabilize your
The
repair. So
annular,
if you can give that stability with something else, so I think it should be good enough. I mean, I know we
Yeah.
need to follow up, but it should be good enough.
We have been doing it in the mitral valve.
Sir.
We have been using these improvised type of annuloplasty rings. They are quite long lasting. So I think you did a very good job, and I think AFIC is probably one of the center which is doing this sort of abstain anomaly surgery in adults.
Sir.
Probably the only one.
Sir.
Thank you.
Thank you.
Thank you,
Thank
sir.
you.
Thank you very much, sir. Now I call my next presenter, Dr. Sikandar, who will present on behalf of Brigadier Nasir, the sinus rhythm restoration in patient with mitral valve surgery with chronic atrial fibrillation. Thank you.
अच्छा ये इससे आगे होता है और इससे पीछे ठीक है Bismillahirrahmanirrahim. Assalamu alaikum to everyone and my respectable teacher in panel. I'm Dr. Sikandar Hayat, Registrar in Cardiac Surgery at FIC, and I'm here to present our five-year experience of left atrial reduction plasty to achieve sinus rhythm in patients undergoing mitral valve surgery with chronic AF. The main objective of our study was restoration of sinus rhythm in patients undergoing mitral valve surgery irrespective of etiology with giant LA and atrial fibrillation. Well, the total patients included in our study were 33, and our study stretched from January 2017 till June 2022 around. And most of the patients who have symptoms, about 25 out of 33 have palpitations and irregular heartbeat, and 22 patients have dyspnea NHY class 2 and class 3, only 11 patients, and 2 of them have thromboembolic episodes, of which one individual had residual hemiparesis, but the most common among them all had enlarged LA with chronic AF. The surgical technique we employed here is generally conventional sternotomy, and after that establishing cardiopulmonary bypass, anti-retroplegia given, and approach we used to do mitral valve via 25 via central guide groove and 8 patients via transeptal. Well, the surgical techniques used for LA reduction is cut and sew and plication. We employed plication technique in our study here. We conducted at FIC. We carried out plication with 3 operolin suture in a circumferential fashion, right starting from posterior left atrial wall, extending across left atrial appendage and closing it, and then from second inferiorly, and then plicating anterior wall with 2 limbs. Here you can appreciate in this diagram the Purulin suture, right starting from posterior wall to left atrial appendage, excluding and then coming anteriorly. And secondly, another limb from posterior inferior wall off. And you can also appreciate we cauterizing the around of the opening of the pulmonary veins, which is usually notorious for ectopics. Here is, you can appreciate the other methods, cut and sew and Mercedes alloplasty, just for the info. The number of patients we included in our study, 76% of them were male and 24% were female. And the valve we replaced irrespective of etiology, either it was degenerative or rheumatic, mitral stenosis or MR. The results came, total patients 33, mortality were 0. Post-op, for 54% of them have AV block, and sinus rhythm among 46%. But those patients who have AV block, they usually achieve sinus rhythm between 3rd and 7th post-op day. And 2 patients have stretched this session to achieve sinus rhythm up to 3rd month. Only one of them had persistent AF at 6-month follow-up. We usually use the method of transthoracic echocardiographic studies to carry it out follow-up at 3 months and 6-month interval. 32 patients who regained sinus rhythm exhibited recovery of atrial A wave. And you can appreciate pre-op LSIs as compared to post-op LSIs, which is actually near to normal. Why we imply this study plication rather than cut and sew is because it's easy to learn, have short cardiopulmonary bypass time and less chances of bleedage compared to its counterpart, which is technically more demanding and with prolonged cardiopulmonary bypass time. If you have any ambiguity, kindly ask. Thank you for your patience. Thank you, sir.
In fact, the take-home message is just valve replacement in a patient with giant LA is the half job done. If the it's a relatively new concept, and for the last 10 years there is much work done on it. Actually, when size of LA is more than, it is said that it is more than 45. It is very unlikely, or 55, it is very unlikely, if it is more than 55, it is in the long term very unlikely that the patient would remain in sinus rhythm. So you will have to cut the size small, near to the normal, if you want to regain the sinus rhythm.
Thank you very much, sir. Now I request my third speaker, Dr. Usama, who will present on behalf of Brigadier Amir. And the topic is a comparative study of mitral valve replacement in mini thoracotomy versus traditional median sternotomy. Thank you.
Thank you, ma'am. Honorable guests, respected seniors, and dear colleagues, I am Dr. Usama Akhtar, resident in cardiac surgery, and I'll be presenting a comparative study of mitral valve surgery via the right mini thoracotomy versus traditional median full sternotomy. This study was performed by Brigadier Muhammad Amir Khan. The conventional approach for mitral valve surgery has long been the traditional median sternotomy. It provides a very good surgical field and approach, and with a very good outcome. However, it is not without its drawbacks. It requires the sternum to be completely sawed through, which damages the integrity of the chest, which can lead to postoperative pain and bleeding. As with the rest of the surgical field, minimal access surgery is also becoming very common in the cardiac surgery as well. And minimal access invasive mitral valve surgery has also gained consensus among the cardiac surgeons in the last few decades. It provides greater patient satisfaction and with the same quality and safety as compared to the traditional mitral valve surgery. Minimal access surgery was defined by a statement by the American Heart Association in 2008 as cardiac surgery performed through a small chest incision that does not include the conventional full sternotomy. The advantages of minimal access is that it reduces surgical trauma and postoperative pain, which leads to early recovery and shorter hospital stay. As whole of the sternum is not sawed through, it leads to decreased blood loss and transfusion requirements, which leads to better cosmetic results and patient satisfaction. However, it is not without its drawbacks. It is a technical, more complex and challenging surgery, requiring a distinct and prolonged learning curve. Initially, an endovascular balloon was used to occlude the aorta to go on bypass, and which had its own complications, such as neurological complications because of thromboembolic events, aortic dissection, and as the catheter was passed through the groin, there was some groin infection and complications. This slide demonstrates the different incisions that can be taken for any cardiac surgery. The first one is the conventional full sternotomy. However, there are some limited extent of the sternotomies, which is lower sternotomy, hemi or mini sternotomy, and mini thoracotomies. Recently, videoscopic assisted surgery is also being performed, and robotic assistance is also being used. The objective of the study was to compare the clinical outcome of mitral valve surgery done through right mini thoracotomy versus traditional median full sternotomy. It was performed at the AFAC. It was a retrospective observational study done from December 2013 to 2023. A total of 744 patients were studied, out of which 73 patients underwent minimal access surgery. The patients were divided into two groups, and a propensity scoring matching was done among these patients. The parameters used were the patient's age, the Euroscore, NYHA classification, LV ejection fraction, their creatinine and total bilirubin level, and the degree of the mitral disease. And based on these, only 62 patients remained in both the groups. Approval was sought from the Institutional Ethical Board Review Board, and the data was gathered from the cardiac surgery registry at AFIC. The different parameters which were measured in both the groups are as flashed. They included some per-operative data and the post-operative data of these patients. The continuous variables among these data were measured as mean and was compared using the student t-test. Percentages were used to describe the categorical data, and Fisher exact test was done. Two-sided p-value of less than 0.05 was considered as statistically significant. Now, this is the preoperative data of these patients. The male to female ratio, the age of these patients, and the NYHA classification in both the groups was comparable and was not significantly different. Similarly, the Euroscore 2, the creatinine level, the bilirubin, and the comorbidities in these patients, such as hypertension, diabetes, and AF, were comparable in both these groups, and there was no significant difference between these patients. Now, I'll briefly touch upon the technique of the minimal access mitral valve surgery. The superior vena cava was cannulated by the anesthetist using the Seldinger technique, and here you can see the venous cannula being introduced. So this is the cannula in the superior vena cava, and this is the CVP. The right side of the patient was draped from the neck to the groin. So this is the head end, and that's the foot end. Here you can see the purse tongue being taken at the femoral artery for the peripheral cannulation, and the femoral cannula being introduced. The venous cannula was also introduced through the femoral vein, and both the cannulas can be seen here. A small incision was then made in the fifth intercostal space by the right thoracotomy, and a wood card was put in place. The exposure was improved using a retractor, specialized retractor for the purpose. Here there is a special, you can see the cross clamp which is now being used for the cross clamping of the aorta. Here is another view of the same clamp. A specialized Elliott retractor was then separately introduced through a stab incision. The rest of the surgery was similar as in the conventional full sternotomy surgery. The mitral valve is excised, and sutures are taken from the annulus of the mitral valve. Here the prosthetic mitral valve is being put in place, and the knot being tied. The knots can be then pushed into the smaller wound using a knot pusher, or if possible and the wound is big enough, using slip knots. And here is the final result of the valve in place. These are the post-operative pictures showing the incision and the chest and the groin. Coming to the results of this study, the aortic cross clamp time and the cardiopulmonary bypass time was significantly more in the patients undergoing minimal access surgery as compared to the patients who underwent conventional surgery. However, the valve size, the ventilation hours, and the ICU stay were similar in both the groups. The number of blood transfusions done and the total drainage was significantly less in patients undergoing minimal access surgery as compared to those undergoing conventional surgery. There was no difference in the reventilation, reoperation, or the pneumothorax rates in both these patients. The wound infection rate and the hospital stay was also significantly less in patients undergoing minimal access surgery. However, there was no difference in the development of hydrothorax or mortality in these groups. I'll briefly discuss the results of these patients. Although the aortic cross-clamp time and CPB time was greater in the patients undergoing the minimal access surgery, and that was due to the technically more difficulty of the surgery and the larger and the more difficult and long learning curve. However, as one might think that because of these parameters, the patient might have worse outcome because of the effects of the aortic cross-clamp time and the CPP, but this was not seen in our study, and it has not been documented by any of the other studies performed. Similarly, the ventilation time and the ICU stay time were comparable in our groups in both these patients, but they have been shown to be significantly shorter in patients undergoing minimal access surgery. These patients, because the integrity and stability of the chest remains intact as the sternum is not completely sawed through. So these patients have a better pre or post-operative response, and they have early post-operative respiratory functional recovery, and therefore the ventilation hours and the ICU stay is much shorter in patients undergoing minimal access surgery. Again, as the sternum is not completely sawed through and there is less retraction on the tissues and less damage, that leads to less bleeding and less inflammation in these tissues, leading to less bleeding transfusion requirements and with decrease in morbidity and mortality associated with with blood transfusions. Because the transfusion is less and there is less associated morbidity and mortality. The incidence of wound complication is also less in these patients, and this has been reported by another study by Grossi et al. However, a study by Felger did not report any statistical difference, but most of the studies have shown that there is a reduced infection rate in patients undergoing minimal access surgery. Our study was also consistent with other studies performed which showed a lesser hospital stay in patients undergoing minimal access surgery. Our study was not perfect. There was two limitations to our studies. As it was a retrospective study, there was some selection bias, and both these groups of patients were not perfectly matched. Had it been a prospective study, it would have been better, less bias in this regard. Also, we did state that it had a low and early. We had a limited early and late follow-up, and we did, and as was stated, that patients did return to their normal life earlier. However, we did not have any quantifiable data to support our statement. So to conclude, minimal access surgery is a safe and effective surgical technique associated with lesser mortality and morbidity. It has some reported benefits such as decreased blood loss, leading to less blood transfusions, decreased ventilation stay, and eventually decrease and a less ICU stay and hospital stay. And it should be used routinely in the surgical management of patients with mitral valve disease. Thank you all.
Thank you very much, Dr. Usama. Any question and answer for this for the talk? Yes, sir.
Excellent talk. So I want you to know what is the international guideline on this. Should we send our patients for minimum thoracotomy surgery or?
There is no consensus still because it all depends on the institutions who are doing this surgery routinely and the training they have imparted on to their surgeons. And even in America, there are less than 50% of centers are doing minimally invasive surgery. Majority of them still using this full sternotomy incision. Long-term outcomes are the same. They are the same, yeah.
Okay. Next, let's move to the next presentation, which will be given by Dr. Danial, cardiac surgeon, AFIC, who will present on behalf of Brigadier Amir Asghar. It's Imran Asghar, sorry, sir. It will be TAVI versus minimal invasive S1.
Assalamu alaikum, ladies and gentlemen. Assalamu alaikum, ladies and gentlemen. My name is Dr. Danial Ahmed Kaman, and I'll be talking on TAVR versus SAVR. Is TAVR the real deal? On behalf of Dr. Imran Asghar. This is the outline of my talk. Traditionally, treatment options for aortic stenosis include surgical aortic valve replacement, transcatheter aortic valve replacement, and palliation. Different factors favor different forms of treatment. Broadly speaking, surgical AVR is favored by a younger age and a longer life expectancy, a bicuspid aortic valve or a rheumatic aortic valve, a need for a mechanical prosthesis, and difficult femoral anatomy or valvular anatomy. TAVR is favored by an older age, few expected years in life left, a simple calcified trileaflet valve, or a preference for a bioprosthetic valve. Multiple comorbidities and a porcelain aorta also favor TAVR. When the patient has a terminal illness with limited life expectancy or a severely decompensated heart, palliation is usually preferred. There are two types of surgical AVRs, conventional and minimally invasive. Minimally invasive can further be carried out via right mini thoracotomy or a hemisternotomy. Now, coming over to the choice of valves used during implantation, there are two types of valves available, mechanical and bioprosthetic. It is important to note at this point that surgical AVR is the only modality through which you can implant a mechanical valve, and it can also implant a bioprosthetic valve. TAVR, however, can only be used to implant a bioprosthetic valve. So the benefits of a mechanical valve can only be achieved through surgical AVR. Numerous factors affect the choice of valves, but generally speaking, younger patients with age less than 50 should receive a mechanical valve due to accelerated degeneration of bioprosthetic valve in younger age groups. And older patients should receive a bioprosthetic valve because of the hazards of warfarin. Reoperations are obviously more common in bioprosthetic valves because of structural valvular degeneration. The hazards of warfarin have to be taken into account, the suitability of long-term anticoagulation, and patient preference. Numerous studies have demonstrated the benefit of mechanical valves over bioprosthetic valves. This meta-analysis, which included roughly 15,000 patients, showed an increased survival and freedom from reoperation with mechanical valve replacements compared to bioprosthetic valves. Similarly, this meta-analysis, another meta-analysis showed a survival benefit for mechanical valves in patients less than 70 years of age. Our patient population is different to the patient population in most trials because we have a large amount of patients with rheumatic heart disease. And various trials and studies have shown that bioprosthetic valves have a poor outcome when it comes to treating rheumatic heart disease in these patients. Coming on to transcatheter aortic valve replacement, TAVR. There are two types. There are two approaches, antegrade and retrograde. The most commonly used approach is a retrograde approach with an access through the transfemoral. Complications of TAVI include paravalvular leakage, vascular bleeding complications, stroke, acute kidney injury, atrioventricular block requiring permanent pacemaker implantation, and rarely annular rupture. No discussion on TAVR can be done without first analyzing the pivotal TAVI trials, which over the years have claimed to extend the indications of TAVR into low-risk groups as well. The recent landmark trials of TAVR conducted in low-risk populations include the Partner 3 trial, the Evolute low-risk trial, and the Notion trial. The 5-year data of the Partner 3 trial supports non-inferiority of TAVI compared to SAVR. And the Evolute low-risk trial claimed that at 4 years, their data supported superiority of TAVR over SAVR. However, there are a number of growing concerns regarding these trials. I'll briefly go over them. The mean age of patients in these landmark trials was well above 70 years of age. So this begs the question, can these results be extrapolated onto younger populations? This study from the International Journal of Cardiology shows that the all-cause mortality at 3 years was 34% in patients younger than 70 years of age. Similarly, data from the Society of Thoracic Surgeons showed that patients younger than 60 had a 5-year survival rate which was significantly higher with SAVR when compared to TAVR. Other complications of TAVR include perivalvular leak, which was shown to be consistently higher in all studies comparing TAVR versus SAVR. and permanent pacemaker implantation, which was also higher in TAVR. How these complications affect patients in the long term should be an important consideration when you're looking to manage patients. Data from the Society of Thoracic Surgery once again showed that complications remain common in the first 30 days, and a worse 1-year survival and health status was seen among patients who developed complications such as paravalvular leak and new pacemaker implantation. Similarly, this study from the American Journal of Cardiology showed that mild paravalvular leak was associated with a significant 1.4 times increased mortality at 5 years compared to surgical AVR. This meta-analysis consisting of roughly 51,000 patients showed that patients who required permanent pacemaker implantation after TAVR had a higher long-term risk of all-cause death and rehospitalization for heart failure compared to those who did not receive a permanent pacemaker. Another important thing to note amongst these trials was the fact that 26% of the surgical patients in the Partner 3 and the Evolute trial underwent concomitant procedures such as CABG, not just isolated AVR. And obviously, concomitant procedures have a worse operative outcome compared to isolated AVR. So the superiority of isolated TAVI compared to a heterogeneous surgical comparator is not appropriate and leads to unintended consequences. Important exclusions from the landmark trials include rheumatic aortic stenosis and bicuspid aortic valve. In fact, there has been no randomized trial to date regarding TAVR in bicuspid aortic valve. Therefore, the role of TAVR in these patient populations still remains uncertain. This study shows that TAVR in rheumatic heart disease has a high incidence of device failure and paravalvular leak, which again, as alluded to before, has worse long-term outcomes. Also, can the results of high volume centers and experienced operators, such as those in the Partner and Evolute trial, be generalized to regions where TAVR is still in early stages? Again, data from the Society of Thoracic Surgery shows that there's a clinically important inverse association with increasing TAVR volumes and reduction in TAVR procedural mortality and morbidity. Therefore, it is logical to conclude that low volume centers have a higher complication rate than that quoted in the trials. There is very little TAVR data available in Pakistan, and it is our request that interventionalists present their data so we can make better informed decisions tailored to our particular healthcare system. Moving on to the experience of AFIC with surgical AVR. Data from 2014 to 2024 shows that we performed roughly 156 minimally invasive aortic valve procedures and 625 conventional aortic valve procedures. The mean age of the patients was 43.7 in the minimal invasive group and 48.9 in the conventional group. Both age groups obviously more suited to surgical AVR than TAVR. And whilst the bypass time and the cross-clamp time were numerically more in the minimal invasive group, in hospital mortality, ICU stay, blood loss, ventilation time and hospital stay were all shorter in the minimal invasive group. Our data is supported by numerous international studies which show, such as this meta-analysis, which shows that mini sternotomy is a safe and potentially more effective approach than full sternotomy in the short term. Other studies show that minimal invasive aortic valve replacement is a safe alternative to conventional AVR with respect to operative and 1-year mortality and associated with a shorter post-operative stay. So, our experience shows that minimal invasive AVR is cosmetically superior, and the cosmesis rivals the benefits of TAVR in this regard. There's a shorter post-operative recovery and stay. There's reduced post-operative pain. Post-operative respiratory functions are better, and many procedures facilitate a reoperation. This begs the question, is minimal invasive AVR a possible alternative to TAVR? We beg to agree with this statement because fewer reoperations are associated with many AVR compared with TAVR. There's equal short-term mortality and a proven long-term survival with surgical AVR. Many procedures address aesthetic issues, which many patients have, and mechanical valve implantation is only possible with surgical AVR. Also, minimal invasive surgical AVR costs roughly 1 million in Pakistan, whereas TAVI procedures are quite expensive and cost 4 to 5 million currently in our healthcare setup. Again, numerous studies have supported this conclusion. This study in the Journal of Thoracic Surgery again demonstrated an equivalent short-term mortality, but lower rates of post-operative PPM, aortic insufficiency, and a trend towards lower stroke rates. So what do the guidelines say? The AHA 2020 guidelines recommend that SAVR should be performed in all ages, in all patients under the age of 65 and those with a life expectancy of more than 20 years. TAVR should only be considered in patients more than 80 or with a life expectancy of less than 10 years. 65 to 80 is a gray area where risk and benefits have to be weighed and discussed with the patient. The European guidelines suggest SAVR in ages less than 75, whereas TAVI should be performed in patients who are older than 75. In conclusion, we believe that surgical AVR remains the gold standard in treatment for aortic stenosis. Mini AVR produces equivalent long-term and short-term results compared to conventional AVR. TAVR should be offered to patients after a thorough review of risk and benefits, and minimal invasive AVR is now a viable alternative to TAVR in majority of the patients. Here are a few images from our clinical practice. This is a hemisternotomy incision. Peroperatively, we can see a femoral axis in this picture. A hemisternotomy, right anterior thoracotomy incision, and peroperative images. This is the final outcome. Thank you. Any questions?
I think we are discussing two different categories of patient, TAVR versus SAVR. TAVR is more like, up till now, it has established a role as an end-of-life comfort procedure in those patients in whom surgery is otherwise contraindicated due to comorbids. But yes, you can compare conventional conventional AVR with the mini AVR. So I think these are two different categories of patients.
Any other questions? Any comment or question for the previous speaker? Thank you very much, sir. Let's move to the last speaker, the last presentation of the session. It will be presented by Dr. Atikur Rahman on behalf of Brigadier Nasir Ali, and the topic is thoracoabdominal aortic aneurysm repair and experience at AFIC. Thank you.
May I start? Bismillah ar-Rahman ar-Rahim. Honorable seniors and dear colleagues, Assalamu alaikum. I am Dr. Atikur Rahman, Registrar in Annual Cardiac Surgery, and Dr. Nasir Ali is our worthy Head of Cardiac Surgery Department in AFIC. I would like to share our experience of thoracoabdominal aortic aneurysm surgeries with you. Thoracoabdominal aortic aneurysms, they are predominant in male. The incidence increases with age, and mortality rate is quite high. A study conducted in India which showed in 8 years only 82 cases reported. This underscores the rarity of this disease. A study in Pakistan showed that 6 cases of non-traumatic aortic emergencies were operated, out of which only 1 case survived. This is the workload since January 2023 till May 2024 of aortic surgeries performed in AFIC. Total 28 cases were operated, out of which only 6 cases expired. 7 thoracoabdominal aortic surgeries performed, out of which only 2 cases expired. This graph shows the ICU stay, ventilation hours, the number of RCC units transfused, and the total number of hospital days. This data is comparable to the international data. Here I will present a case report of elephant trunk technique for arch replacement. Hans Bost for the first time described this technique for arch replacement. The frozen elephant trunk has a portion for arch and a stent for descending part of aorta. while the hanging elephant trunk has a tubular part for descending part of aorta. It's a newer procedure and it's performed in either 1 or 2 stages. Few advantages of this technique are it provides a graft that is accessible downstream from the arch. It obviates descending aorta cross-clamping during second stage surgery, and this provides a proximal landing zone for TAVR. Now coming to the case presentation. A 45 years old male, resident of Faisalabad, nursing assistant by profession, known case of hypertension and aortic aneurysm since 2019, however non-compliant to medications, presented with severe chest pain and shortness of breath for last 5 days. A diagnosed case of chronic aortic aneurysm since 2019, presented initially on 5th January 2024 to emergency department of CMH Multan with acute onset of severe chest pain radiating to front and back, not relieving with medications or change of posture. It was associated with shortness of breath, which was not relieving with change of posture. After resuscitation, he was transferred to FIC. He was hypertensive, casual smoker, and Naswar addict. He was tachycardic, dyspneic with high blood pressure. General physical examination was unremarkable. Abdomen revealed mild tenderness in epigastrium, and breath sounds were absent in left lower part of chest. His remaining investigations were normal, except his echo report again showed normal valves with EF of 60%. His CT aortogram confirmed aortic dissection starting from arch of aorta till the level of renal arteries. There is a clear-cut dissection flap you can appreciate starting from the left subclavian artery till the level of renal vessels. This is 3D image of the same patient. Diagnosis of extensive acute aortic dissection was confirmed and surgical intervention was decided. He was kept in CCU for optimization and critical care. His pre-anesthesia assessment was done and family was counseled regarding this high-risk life-saving surgery. Surgical plan was decided in consultation with vascular surgeon. First, a subclavian carotid bypass procedure was performed and 6 mm PTFE graft was used with uneventful recovery, followed by elephant trunk technique in 2 weeks. On 31st January, his arch replacement surgery was performed. We planned our cannulation with anti and retrograde cerebral protection during DHCA. While we were achieving hypothermia, proximal aorta was dissected out and proximal anastomosis was done. Meanwhile, we took control of right brachiocephalic and left common carotid arteries. Circulation was re-established and end-to-end anastomosis was done. Cardiopulmonary bypass time was 217 minutes. Cross-claim time was 175 minutes and DHCA time was 55 minutes at 22 degrees centigrade. Post-operatively, he was kept in ITC for 32 hours with moderate inotropic supports and then shifted to HTU and later on to ward. After 7 days, his CT aortogram confirmed patent branches. You can appreciate on this. He was ambulatory, tolerating orally well, and discharged on 19 post-op day. His 3 months follow-up confirmed his compliance to medications, healthy and being well. He joined his clerical job in April. His next review will be in July 24. These are the causes, risk factors of aortic aneurysms and dissection. As the luminal diameter increases, pressure also increases and dilatation occurs, while progressive dilatation results in dissection and rupture. As per AHA guidelines, intervention in Marfan's is indicated when its diameter exceeds 5 centimeters, and in other cases, non-hereditary aortic dilatation, it is 5.5 centimeters. I would like to conclude my talk with this take-home message. With the help of diagnostic modalities, we can early diagnose these cases. If suitable selection of cases is done, in elective cases, we can improve our results. And multidisciplinary team work is the ultimate need for smooth and successful outcome. I thank you all for patiently listening.
Excellent and remarkable presentations. from Dr. Atik. I would just like to add that at FIC, we have been routinely doing the aortic root and ascending aorta replacements with very good results comparable with the international centers. But presently, we have been extending our expertise to the aortic arch replacements and thoracoabdominal aneurysms and all aortic type B dissections. So we have been doing these aortic arch replacements, and this was done, which was presented. It was a modified approach, and the problem we are facing. I mean, we don't have customized aortic grafts, but we have been, we have been doing that with all these difficulties. But the results for the aortic arch replacements and thoracoabdominal replacement, extending from left subclavian up till the iliac bifurcations, we have been doing it, and the results, I think they are improving. And thank you.
Thanks. Thank you very much. I just want to ask one question, please, from even the panel. What is the role of the right ventricular function in just having this very complex surgery of the aortic arch replacement, especially in the type A aortic dissections? Because I've just seen a patient whose RVCDA was 7 and TEPSI was around 12, 13. RV size was in normal limit. Ejection fraction was 45, but the surgeon procured it very high risk surgery and just put its hands off with this RVSTDA of the 7. And next part of the question is this: what's the treatment plan you go on after having this all of the graft placement, either single antiplatelets or something? What else need to add on it?
The thing is that this is not our choice to say no to any patient, because they are very critical patient. Those having acute dissections, we cannot refuse any patient even with the bad LV function or RV function. So it has to be done, otherwise mortality is almost 100%. So we do undertake such endeavors in routine now. Just before this conference, we have received an airlift emergency from Quetta. They landed up in AFIC, and it was just on the night, on Friday night, we were busy in doing thoracoabdominal surgery at AFIC. So we do not have the choice, because probably AFIC is one of the center which is doing thoracoabdominal surgeries on regular basis now.
What's the role of the medication over it? You go on with a single antiplatelet?
Not to that extent. Our, in fact, the intention is to keep the blood pressure low, and it is anti-impulse therapy actually. But if you are implanting a mechanical valve, yes, you have to meet that criteria as well.
In that aspect, if we are replacing with the valve, aortic valve, then definitely anticoagulation therapy. Otherwise, for the grafts, whether they are in the arch or thoracoabdominals, initially we give dual antiplatelet therapy for some time, for few weeks. Then to the single antiplatelet therapy, it would be good enough. There's no need for anticoagulation for that purpose. And second thing, for the right-sided heart dysfunctions, they are literally not the contraindications to proceed with these procedures. And usually the patient presenting with these, these are usually presenting in the emergencies, and they usually have low cardiac outputs, low ejection fractions. Thank you.
In fact, this elephant trunk procedure is probably first reported case in Pakistan. We do not get the customized branch graft which are used in the Western world. So we are sort of making our makeshift type of grafts, and we are doing whatever is available with us.
Thank you very much. By this, we come to the end of this session. I thank my experts, speakers, and audience for keen listening and interest. I conclude this session with best regards and thanks. Now I request Brigadier Asif Nadeem to kindly come to conclude the conference and for vote of thanks. Thank you, sir.
Hello. So thank you very much, everyone. It was a good conference, and it would not have been possible without your participation. And we are very much thankful to the pharma teams and industry, because without their cooperation, such an endeavor could not have been accomplished. Thank you very much, and hope to see you in next year, inshallah. Thank you. So can we have a group photo with the pharma team?